The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. We'd like to welcome you to this online Epilepsy 12 how-to webinar, the first of what we hope will be a series of webinars which will help to clarify aspects of the Epilepsy 12 National Clinical Audit. We're delivering this webinar from the offices of the Royal College of Pediatrics and Child Health, and we believe there are about 40 people joining us at the moment, which is fantastic. Hopefully we'll get a few more as we go along. By way of introductions, my name is Karina Green and I work as Project Administrator for the RCPCH Clinical Audits. I'm joined by Calvin Down, Epilepsy 12 Project Manager, Melanie David Vivek, Epilepsy 12 Project Coordinator, Muster Rahman, Project Administrator, and Dr. Colin Dunkley, Consultant Paediatrician and our Epilepsy 12 Clinical Lead. Our colleague Lizzie from the College IT Department is also helping us to deliver this session today. So let's have a look at what we'll cover. We hope to cover the following topics, and we will do this via sharing slides, providing commentary, and showing some demonstrations from the Epilepsy 12 data platform itself. And while this won't be a fully interactive session in the sense that you won't be able to ask questions over the phone, you will be able to submit questions for the team throughout the webinar by using the message box function. And Lizzie will help to collate and pass on your queries to project team members as they come in. We'll try and answer as many as we can during the session, but we'll follow up on any that we aren't able to address immediately, and we will share the responses with all participants by email afterwards. In addition, we're going to record this webinar and we'll make a copy of it available on the Epilepsy 12 project website within the next few days. So I'll now pass you over to Colin, who will take you through the patient eligibility criteria for the audit.
Good morning, everyone. Thanks, Karina. So this is a new experience for me presenting via webinar. Thank you very much for finding time on a Monday morning to join us as we go through some of the features of Epilepsy 12. Thanks for all those who've started with the Epilepsy 12 data entry. We've had lots of positive feedback. We're now going to focus on some of the issues that we think would be helpful to clarify. We know that people are at different stages of participation. So we've been live since the 12th of July. Some people have already found they're well on the road. They've registered patients, verified them, and begun to fill the first assessment forms or the first year forms. Others are having more difficulty. And we're going to focus particularly on patient eligibility, as that's been a focus of a lot of questions. So the slides you'll see are going to be what I refer to as we talk through the features. So one of the key dates to have in mind is the 12th of July, and the key intervention is the First Paediatric Assessment. So the children who are eligible for Epilepsy 12 will have had a First Paediatric Assessment after the 12th of July, and that is an assessment where a paroxysmal episode or a number of paroxysmal episodes was a feature of that assessment, and that assessment will have led on to that child having an EEG undertaken. So it's a very distinct group of children defined by the fact they've had a first paediatric assessment where paroxysmal episodes are considered. And once children meet those criteria, then those are children that can be entered into the web platform. So we'll go on to the next slide. So the Epilepsy 12 platform will only accept children who are NHS patients. So children who remain private patients won't be eligible. Common question has been about age limits. We've taken the premise that there's no defining age for inclusion in the audit. As long as they've had the first assessment within a paediatric service, then that child or young person is eligible. So, for example, if they've had a paroxysmal episode and then are seen in an adult service, it doesn't matter what their age, they would not be eligible. If they've not been seen by a paediatric service at all, for example, GP or primary care or emergency department, then they're not eligible at that time, although of course they might be later on. The other change compared to previous rounds is that the audit can accept patients who we might think of as neonatal patients. Again, the same criteria apply. They need to be seen by a paediatrician, and they need to have had paroxysmal episode or episodes, and then an EEG will need to be undertaken. So I hope you're following my talking through quite complex eligibility criteria, but I'm hoping you find it clearer. So the first paediatric assessment, just so that people understand that is where a child is seen by a paediatrician in a paediatric team, and that might be the first clinic appointment, or it might be an episode which results in admission for that child. So the child has had a paroxysmal episode or episodes, and they're having their first review by the paediatric team. If the child is seen in emergency department and they're not seen by the paediatric team, then they wouldn't be eligible. If the paediatric team goes and reviews that child in the emergency department, then they are eligible. There's one or two health boards where it's a bit confusing in that the paediatric service itself runs the emergency department service, but in the most instances services don't run like that. So if the child is purely seen by the emergency service, then that doesn't count as their first paediatric assessment. It's only those children who are admitted or referred on to a first clinic and then they're seen as a paediatric assessment. It's potentially a confusing eligibility criteria, but it is simpler to describe children in this way rather than the confusion as to whether a child has epilepsy, which is a difficult inclusion criteria. So we've tried to make it simple that any child with a first paediatric assessment after the 12th of July who has an EEG is eligible for entry into the platform, and then the platform questions over time make it clear what data needs to be entered for that child, and we should hopefully end up with potentially all children with epilepsy presenting after the 12th of July. That's the aim. This next slide is about consent, because this is audit and we've achieved 251 approval. We don't need explicit consent from families for children's data to be entered into the platform. One of the nice things about the platform is that we can now put in the child's name and identifiers and then track their care over time. So it's not anonymous to us as clinicians using the system. It's good practice to inform patients that their data is being put into the platform, but they don't need to give explicit consent. We've supplied posters to teams to display, so if EEG services are registering or trusts or health boards are registering, then pop the posters up and give people the opportunity to know that their data has been entered into the system. So any questions? Just to describe how the question process will work, you submit a question through the platform and then the team will select questions, and then we'll talk to questions submitted by listeners. If there's no questions, we'll move on, but I'll leave a little time for people to enter any questions they may have.
I will take over now and describe to you the data platform user types and the process of registering patients via the Epilepsy12 data platform. So let's have a look at the data platform user types and permissions. Patient identifiable data will be processed through the Epilepsy12 data platform, and so we need to ensure that good governance and security is paramount. Each health board, trust and EEG service that signed up to participate in the Epilepsy12 audit had to do so via a designated lead, and with the approval also of its Caldecott guardian. Furthermore, anyone given user access to the system has to be approved by their respective designated lead. We have full guides on user registration and different user-associated permissions available on the Epilepsy12 website. But in summary, for health board, trust, pediatric teams, there are 3 user types, which are designated lead, editor, and reader. And each of those have distinct user permissions. There are also 3 similar user types for EEG services with their own user permissions, as you can see here. So we're just going to have a look on the live site now at registering a patient via an EEG service. Now, though we are using a live site, we are using fictional dummy services. Bear with us 1 second while we change the screen. Okay, so there are 2 ways in which a patient can be registered onto the Epilepsy12 clinical audit, either by the pediatric team within the health board and trust, which undertook the first assessment for a paroxysmal episode or episodes, or by the EEG service to which the patient was referred for a first EEG. As I mentioned, this can only be done by approved users. The support of EEG services is key to the success of the clinical audit phase, and we can see already that for most patients who are on the data platform, it's been the EEG service that has initially registered the patient. Let's start then by looking at registering a patient via an EEG service. In the following example, I'll log in as an editor type user for a fictitious demo EEG service. So the first step is to go to the data platform login page and accept the user permissions, which I've done. And then you'll be presented with the login screen. Your username will be the NHS email address that you indicated when registering as a user, and you will have chosen your own unique password. If you forget your password, you can click on the forgotten password link and follow the steps to reset it. Once you're logged in, click on the EEG registrations button, and you will be taken to the initial patient registration form record management screen. From there, click on the Add Record button to open up a new patient registration form. Now, Collins indicated the main patient eligibility criteria earlier, but as a reminder, the main points to note when filling out the form are that only NHS patients will be included. The patient must have been referred by a paediatric service and not an adult service. At the point of saving the form, the system will check against the entered NHS number to check whether the patient is already on the system and therefore ensure that duplicate patient entry can't occur. Patients will be excluded if they have had previous EEG for a paroxysmal episode or episodes. And users should be very careful when answering the final question 1.10 on the form, as they have to choose from a drop-down list the name of the health board or trust which referred the patient for the EEG. Now, once all that is done and all questions have been answered, click Save. So we'll just fill those last few questions out, being careful, as I said, to choose the correct health board or trust. And if the answers meet all of the inclusion criteria, then the form header will go green, just like ours has, indicating that the form is complete. Now, if the form is complete, a Submit and Lock button will appear at the top left of the form. Clicking on this button will lock the form, and it will also crucially send the registration through to the indicated Referring Health Board of Trust's clinical case list on the platform for them to check and verify. Click Exit to go back to the patient record management screen. You'll still be able to view the details of the patients that you have registered, as they will remain recorded within your patient registration record list. And on the EEG service side of things, that's really it. So we'll take any questions you have on that now.
I'm going to take a few questions that we've had coming through. So some of it relate to what you've just talked about, Karina, and then some talk about the wider ascertainment questions. So we've had a question from Nisha. Is it a problem if your local EEG department does not join in the audit? As you've seen in the demonstration, we've just had the EEG service can enter patients and help registration. We've gone for a two-prong approach, really. So the idea of using EEG services is that means we get a very broad catch of all those children who meet the inclusion criteria. So you can imagine, as a single clinician in a hospital or community setting, it's very difficult to keep up to speed with who's presented in which clinic with which seizures, who's come in as admission. So the entry point of using First EEG is a really helpful handle to make sure we catch all children and don't stress about whether we've found them all. So for that reason, we have aim to have much of the registration undertaken by the EEG department. So for example, in my trust, we've been live for a few weeks now, and they've been putting in each child who my service has referred for EEG. It is possible to undertake the audit without EEG services registering the patients, but it's much more difficult. If you're having difficulty encouraging your EEG service to take part, let us know, and we'll support them taking part. All trusts should be taking part in this national audit, and there's various ways we can make it easier or encourage them to take part. Most EEG services are taking part, but some are needing some further help and encouragement. Another question we've had from Emma. So if a patient was referred on the 10th of July but seen after the 12th, do they still meet the inclusion criteria? So no, they don't. So it's the date of First Paediatric Assessment. So it's quite a strict cut-off. So obviously there'll be some children who would be excluded in that their first assessment was before the 12th of July. If they were seen after the 12th of July and the first episodes were thought to be non-epileptic, and then they later had an EEG, they would still qualify. So we've had a question from Arnab around that. If a child had a non-epileptic episode at their first assessment, but then later on they were thought to be possibly epileptic and had an EEG, yes, they would qualify. They've had a first paediatric assessment after the 12th of July, and they've gone on to have an EEG. And that illustrates the reason why we've had quite broad inclusion criteria, so that we make sure we catch children with epilepsy, because they often come out of the woodwork, don't they? So they may be unclear or uncertain, and then the diagnosis of epilepsy comes later. So a lot of the ascertainment is around catching all those potential children who may later go on to have epilepsy. So I'll leave that for questions for the moment. I'm just looking through the question. We're getting lots of questions, so I'm just looking through to see whether there's any related to this particular topic. How do we catch those where an EEG is indicated but not done, is a question by Rebecca. So these are the children who really we would hopefully be cited to as a trust. They may be more difficult to catch, but I think most children we're interested in will have an EEG attempted. So EEG services have been asked to register those who've been referred, whether they attend or not. So that's the main answer to that question. If EEG is done by another trust, then again, that's difficult. If you discover there's a child who you think should be registered, but you haven't undertaken the first paediatric assessment, again, let the team know and we can help find a way to enter them into the platform. Nish has asked, does the first paediatric assessment need to be someone who has a special interest in epilepsy? No, it can be anyone in the paediatric team, whether it's a SHO or registrar or consultant without an interest. Anyone within that paediatric team counts as the first paediatric assessment.
Thank you, Colin, for answering those questions. Any further questions that we haven't been able to answer, we will be sure to follow up and email around the answers. So we've now seen how EEG services can register patients. So let's look at how health board and trust users within paediatric teams can register patients. I'll hand over to my colleague Calvin, who will take you through the process.
Thank you, Karina. So we're going to look at how health boards or trust paediatric teams can register a patient. Paediatric teams can be involved in patient registration in two ways. They can either confirm EEG registrations or register patients from scratch themselves. And we're going to start by showing how they can confirm and verify patients who have been initially registered by an EEG service. So first of all, we've logged in, as you'll see, as a user for the quite embarrassingly named Calvin Downs Hospital NHS Foundation Trust. And clicking on the Trust Clinical Audit tab, which we've already done, takes you to the clinical case management screen for your trust. Now, if your team or EEG service had yet to register any patients, the case management list would of course be blank and you wouldn't see any patients, but we've obviously had a little bit of activity on there already. So in this example, we can see there's a couple of patients, as I said, on the list already. Now, when we looked at patient registration by EEG services, we saw that the EEG service had to indicate in its registration form which health board or trust referred the patient for a first EEG. And in that example that we went through, the EEG service indicated Calvin Downs Trust as the referring trust. And we can see that the patient in question does now appear in the clinical case list for this trust. The paediatric team will also know that they need to check and confirm the registration, as the patient appears as not yet verified in the verified column and incomplete under the record status. And then to check and complete the patient EEG service registration, we'll click on the pencil icon to go to the form. So what you would do first of all is you go through all the details that have been entered by the EEG service and check that they match the details that you have for the patient in question. The key action really is to indicate for question 1.10 whether the first pediatric assessment was undertaken by your trust. If you were to answer no to this question, the patient registration would be excluded. And in such cases, we would ask you to contact us and let us know the patient's case ID, not the patient's name, so that we can go back to the EEG service and ask them to check whether they indicated the correct referring trust when registering the patient. But if you have filled out all of the questions correctly and indicated yes to question 10, clicking Save should turn the registration form header green, indicating that it is complete. Your next step would then be to fill out the verification tab. The verification form is the final step in confirming that a patient should be entered fully into the clinical audit. Only paediatric team users have to complete the verification form, and it asks the paediatric team to indicate definitively that the child had a paroxysmal episode or episodes prompting a first pediatric assessment, that the child had not had any previous EEGs or pediatric assessments for a similar episode or episodes or epilepsy prior to this recorded first pediatric assessment, and it asks you to enter the date on which the very first paediatric assessment for this episode or these episodes occurred. Now, the date of the first assessment is really important as it decides which of the Epilepsy 12 patient cohorts a patient will be part of. We don't really need to go into the patient cohort in much detail here, but the first cohort of patients will be those who had a first paediatric assessment undertaken between the 12th of July and the 30th of November 2018. And just a quick note to say we've extended the deadline for the first cohort, which was previously the 30th of September. So now it will go up to the 30th of November, but you really won't notice anything different within the system itself. The final questions, which we've shown you how to complete, are to enter the patient's home postcode and the address of their GP. So if everything has been filled out correctly and all inclusion criteria have been met, the form will appear as green and complete upon clicking the Save button. This should then prompt a Submit and Lock button to appear, and we'll pause while that comes up. So submitting and locking the record will lock down the registration and verification forms, and this means that the clinical details surrounding the patient's first paediatric assessment for a paroxysmal episode or episodes can now be added. So we'll click Exit and go back to the case management screen. So that was a Health Board of Trust checking off an EEG service registration and then verifying it. What we'll look at now briefly at is how a Health Board of Trust can actually register a patient from scratch. So from the case management screen, click on Add Record, and you'll be taken to a blank patient registration form, which is set out as shown on screen. So we'll just go through entering data into that form, and you can see that it basically mirrors the EEG registration form. And whilst the answer to question 1.10 may seem obvious, it's still important to check and indicate that you are the trust that undertook the first paediatric assessment for the patient in question. Enter data for all of the fields, and if you've missed any out, they will be flagged as red and required when you hit Save. But if you've completed all of the required fields correctly, clicking Save will turn the form green and complete. As we see there, we've shown how any missing data fields that haven't been completed will be flagged as required. So we'll just amend that, save the form, and it should go green. So the next step would be to verify the patient, but as we've already shown you how to do that for the EEG service, we won't go through that process again. Now, before we go on to look at adding and completing a first paediatric assessment form for a patient, we'd just like to add a quick note about the weekly reminder emails which are sent to all users within participating paediatric service teams. You've hopefully noticed by now, as a Health Board or Trust user, that you're sent an email directly from the Epilepsy12 data platform each Friday, which notifies you of how many patients within your clinical case management list have been initially registered, but who still require verification. So we'll just take a pause to see if any further questions have come through following that section.
Thanks, Calvin. So it's wonderful. We're getting lots of questions through. So I'm going to pick up a few relating to the processes just discussed. So Christina's asked, my EEG has included all the patients that they did EEG on, and not all have epilepsy. How do I remove those who don't have epilepsy? So the answer is you don't need to remove them. So the system will track all children who are registered and verified, and then track their ongoing diagnosis. So in time, those who turn out not to have epilepsy will fall off the system. Those who do turn out to have epilepsy will remain in the system. So the ascertainment and tracking process is built into the platform. So all children who verified will be in your list. And then the children who turn out to have epilepsy, you'll be able to enter and update their data as you continue their care over the first year. Emma's asked, will the paediatric team get informed via email that EEG have entered a patient, or do we need to check the platform for these patients? So Calvin's just alluded to the weekly reminder, so that'll show you how many patients that have been registered by the EEG department. So I'd suggest dropping into the platform from time to time, verifying those patients. If you've got a patient in front of you and you're not sure whether they've been registered or not, then again, log in, have a look at the list, and you should be able to quickly see whether they're there or not. The system won't let you enter a patient in twice, so duplication is avoided. Rohit's asked, do we need to do EEG for first seizures or paroxysmal episodes? So the platform shouldn't mean you change your criteria for doing EEG. We still continue as per current practice to do EEG when clinically indicated. So if you don't think a child needs an EEG, then don't request an EEG and don't put them into the system. It's just those children who are having EEG for current clinical indications, although those are the same children we should be registering into the system. So I'll pause there for questions, and we'll move on to the next section.
Okay, thank you, Colin. So we're going to go on to looking at how to add details of the first paediatric assessment, and we're going to do that by referring to the patient who we just verified just now. And just another note to say that many people have asked us when this form should be completed. So as Colin, I think, has alluded to anyway, without wishing to be too prescriptive, our advice is to try to complete the first paediatric assessment form on or as close as possible to the date of the first assessment itself. But let's move on to show you how to do that. So patients within the clinical case management screen list whose registration and verification forms have been submitted and locked are shown as trust verified within the verified column and submitted within the record status column. These patients also have a plus button on the far left-hand side of the patient's row of information. And we can see that the patient we verified just now has that status, and to start a first assessment form submission for them, we would click on the plus button and then click on the Add First Paediatric Assessment button. So you'll see now that the first paediatric assessment form is opened up on the screen. The patient's demographic details appear on the top left of the form, as does an indication of the Epilepsy12 cohort that the patient is part of, based on the date of the first paediatric assessment as entered on the verification form. The key on the top right-hand side of the form indicates how data completeness is described for each of the form sections. There are 10 sections in total, all of which need to be completed. Help note buttons appear next to the questions within the sections to help guide you through data entry. So, sections 1 or 2 are combined into a single tab, and this should always be completed first. This first tab is very important as it contains some key data fields, including the patient opt-out field. So Colin had already mentioned earlier that consent is not required, but we do have to provide the option for a patient or their family member to opt out of the audit. So this could be recognized by indicating yes against the first question in tab 1, but we'll actually indicate no on this occasion. If we had clicked yes, that would mean that no further questions within the form can be answered, and the project team would not be able to process any data for this patient. We won't go into it in too much detail now, but the decision can be reversed if the patient changes their mind down the line. Question 1.3 asks you to indicate if the patient is still having follow-up under the care of your paediatric service. The form still needs to be completed, even if you answer no to this, because we already know from having registered and verified the patient that you did actually complete the first paediatric assessment, but it's still helpful for us to capture the state of current follow-up. Question 2.4 is particularly important as the way in which it is answered will have a bearing on how the further sections 3 to 10 of the form can be completed. Sections 3 to 10 of the form will only open up for further data entry if a patient is indicated as having a diagnosis of epilepsy, as defined by indicating for question 2.4 that the child has had an episode or episode where one or more are considered epileptic, and thereafter indicating for question 2.4i that these were either 2 or more episodes more than 24 hours apart, or that the patient was diagnosed as having epilepsy for another reason. If the answer to 2.4 indicates that the child did not have an episode or episodes where one or more were considered epileptic, then you will need to describe those non-epileptic episodes. And we'll initially show you what would happen if you actually indicated that the child did not have a diagnosis of epilepsy. If the patient is indicated as not having had a diagnosis of epilepsy, then sections 3 to 10 will not open up for data entry. And we're just saving that to show a good example there actually of how a required field was missed. And we're indicating now the non-epileptic episode type, saving those details. And we can see now that the first tab has gone green. So we've said that this patient had non-epileptic episodes. But if we now look at sections 3 to 10, it's still important to complete the form by clicking through each section and turning them green and complete. Now, they're deemed to be complete in such instances without a diagnosis, and that's why no data needs to be entered. The form could still then be locked, submitted and locked, at the point after which you've turned each section green. And the reason we want you to still do that is because, as we'll see in some of the following sections, you can still add a first year of care for that patient. And indeed, as we know, the diagnosis may change over time. But what we've done here is to show you how you could submit and lock a record for a patient that doesn't have a diagnosis of epilepsy. But what we'll actually do is go back and look at a patient who did have a diagnosis of epilepsy and how their diagnosis would be locked. What we're going to do is go to a patient, almost like Blue Peter, if anybody remembers that, which we'd prepared previously. So this is another patient we're going into because we didn't want you to watch us have to click through all of the sections and put all of the data in. But for this patient, we had entered on the first tab that they had a diagnosis of epilepsy. So for 2.4, we had said that they had an episode or episodes where one or more were considered epileptic and that there were 2 or more episodes more than 24 hours apart. That had allowed us to go into sections 3 to 10 and enter data throughout each of the sections. Now we'll just take you to section 3 to show how information that a designated lead had put into their trust profile would be pulled through to sections 3. And so it's really important that the trust profile is kept up to date, because that gives you the options that you can see that are available to us for some of the questions within this section. The key point to remember, though, is you've got to complete some information for all of the required data fields within each of the sections. Ultimately, though, how your health board or trust relates to the against or performs against the key performance indicators will actually be measured against your first year of care form. Now, as I said, we didn't want to take you through data entry for all of the fields, but what we're going to do here is show you that we've entered and completed data for all of the sections apart from section 8, which covers care planning. Now, some questions in the form, such as those within this section, have a format that allows you to add multiple layers of information. For instance, we can see for question 8.8 that we have recorded details of 2 separate discussions about general participation and risk. So you can see we can add more than one instance of information for a particular question. We can highlight any missing required data fields by clicking Save. And as we can see here, we've got one outstanding question, and we can fill that in, save the record again, and we can see now that the care planning section is green, and indeed all sections are green. Now that in turn allows a submit and lock button to appear at the top of the form. Clicking on it locks down the information on the form so that it can still be viewed but no longer edited. We can now exit the form and return to the case management screen to see how to add a first year of care form for this patient. And I'll now hand over to my colleague Mel, who will talk us through the process of entering data for the first year of care form.
Thank you, Calvin. The first year of care form seeks to capture the details of care that is provided for a patient up to a point 12 months on from the day of their first paediatric assessment. We just saw how to submit and lock the first paediatric assessment form for the patient case number 607. And if we click on the plus symbol next to this patient, we can see that we now have the option of adding a first year of care form for them. Click on the first year of care form to open it for data entry. Sections 1 and 2 have to be completed again, as with the first paediatric assessment form, covering opt-out options, trust follow-up, and diagnosis status. We will continue by indicating that the patient still has a diagnosis of epilepsy via our responses to questions 2.4 and 2.4i. Clicking Save should turn tab 1 green and confirm at the top of the form that we are now in the first year of care. If we then click through the sections 3 to 10, we can see that the data that we entered into the first paediatric assessment form has pulled through to the first year of care form. So nothing has been lost, and you aren't being asked to start again from scratch. What you should do is add information to the form throughout the year. For instance, by updating section 5 to add details of any new seizures, or adding details of when any new treatments were started, as demonstrated on the screen now. Keep updating the form as and when details of care change, and only once you reach the end of the year should you use the check boxes at the bottom of the section to confirm that all of the information within is up to date. This will turn the section heading to green and complete. However, you will not be able to submit and lock the form until 12 months has passed. the date of the first paediatric assessment, We're just going to pause there for any questions that might be coming in.
So thanks, Mel and Calvin. So I'm hoping people can see that this provides a powerful way to try and identify the whole population, and then for an individual child with epilepsy, the potential to track their ongoing care and the quality of care over time. So there's two principal functions: the auditing of the population, and then the ongoing description of care for the children with epilepsy. And we've built a lot of logic into the system so that the data set is small for those children who don't turn out to have epilepsy, and quite detailed for those who do have epilepsy. So I'm going to look at questions we've had now. If you want to add some more questions, then fire away. They pop up on my screen. I'm going to answer one from Rohit. What if the patient's parents are not informed and so not sure about the consent status? So that's harking back to the consent issue. So we don't need to capture consent for patients. So if they're entered into the system, it's fine for us to add ongoing information for that child. It's good practice for when we see children in clinic who are in the system and on the platform, for them to know that their service is participating in Epilepsy12, but we don't need to capture their consent. If, however, they tell the service that they don't want to take part, then we would describe that in the platform and their details would be removed. Usher's asked, will we get reminders about completing first year of care, a form at the correct time? And the answer is yes. So at the moment, the email reminders are about ascertainment, but as time goes on, we'll be telling you how many patients need to be verified or have the different forms completed to the different dates. And Calvin alluded to the cohort dates, and those dates are quite important for helping us describe to you when to get the information in. And I think some services will do this really proactively and prospectively and be up on children as they go. Other services will be a bit more last minute and do it in a more retrospective fashion and do it into the data just before the deadline approaches. But we'd encourage you to do it as you go. That's good practice. You'll get more value from the system, and the whole thrust of the new Epilepsy12 this round is to move to a more prospective, real-time, whole population approach. Nisha's asked, some patients have complex epilepsy and may need regular reviews, drug changes. You want all of these changes captured. So the answer is yes. That may sound overwhelming, but remember, if you're doing this just for new patients, often the complexity piles up over time, and it's just entering one drug at a time. So over the first year of care, if you update what you've done in the last appointment, then you'll be able to keep track. And you'll see as we show you that we've tried to build in a lot of value into the system. So at the moment, we've shown you the difficult bits of putting data in. We haven't yet shown you the value of what you'll get out. So there are elements of Epilepsy12 which will show you timelines for drug treatment, emerging diagnosis, outcomes, and summaries of diagnosis. So putting the data in should be useful for providing ongoing care for the child, particularly those with complexity. So I'm going to stop there for questions and head back to Mel and Calvin.
Okay, thanks, Colin. So as we've still got a little bit of time left, we'll show you some of the added benefits of the system. So At the top of the patient's first year of care form, you will see a timeline report, which you can click into and be provided with a summary of aspects of care, which can be accessed by hovering over the red lines within the timeline. These include elements such as the last seizure recorded, which treatments were started, and elements of care planning. Then you can click on the care planning button, which provides a more detailed summary of all of the aspects of care planning that have been recorded for the patient in question. These are just two of the summary report functions that are already on the system, and we'll be adding a describe diagnosis summary output function shortly, and a live performance indicator dashboard, hopefully by December. I will now hand you back to Colin for some final words.
Thanks, Mel. So we're going to move towards closing the webinar. I'm hoping you don't feel overwhelmed. So I know when you're asked to do new things and use new systems, they can be a bit opaque and ambiguous and tricky. What we've tried to do is walk you through the system in such a way that when you're trying to use the system for an individual child, it's actually quite straightforward. You have to think about the questions in front of you, but the system should guide you through. There's a few tricks to learn within the system, which we've highlighted in terms of registration and ascertainment, and then understanding the concept of First Paediatric Assessment and first year of care. But once you get your mind around that, then we're hoping the system is fairly straightforward to use. Make use of your wide team, so it doesn't have to be a solo effort. You can allocate as many users from your trust to the system to help you with the tasks. So for example, within my trust, myself and another consultant are taking part, and our epilepsy nurse, and then a registrar is going to help us with the ascertainment and verification. So different tasks will be taken on by different people. I've had about 27 children put in so far, and so far only 1 or 2 of them have got epilepsy. So we're doing okay, and I'm going to keep looking at the system and see how we're getting on. And then when I start seeing those children with epilepsy, update the system as we go. You can see the tools like the care planning tracker and the timeline may prove really useful for you to help the team manage children. So for example, if a family rings up and the epilepsy nurse provides some information about driving, for example, over the phone, the system can be updated there and then, and you get a real live tracking of the care delivered for that patient. We're constantly trying to update the system, so any difficulties you have or questions, contact the team. If there's problems within the system, we'll try and put them right, and then we'll let you know about the added value we're adding to the platform over time. As you can imagine, it's a big, substantial project to move towards whole population epilepsy tracking. So bear with us and support us, because as you know, we're really keen to transform the care for children with epilepsy, and we think getting this whole population view and a service view will be one of the key ways to help you, but also make the case for those with the power to make changes to services. So I hope in this project, in between all the clicks and the forms, that you can see the big picture. We've just put on the screen the ways to contact the team. So you can contact us via the email. You can phone us during working hours. The information is kept up to date on the College of Paediatric website, and then join in via Twitter. There's lots of people tweeting and describing their improvements, and we hope to get a dialogue around positive change off the back of this. This webinar has been recorded. Thanks for all those who put questions in. If we've not had time to look at your question, we will be answering all those questions and feeding you back. Hopefully you should get your question answered, and then we'll keep an ongoing log of frequently asked questions, so that you can see what people have been entering in. So I think that just leaves me to thank the team. Thanks to you all for joining. Thanks to our panelists. Thanks to the college for hosting this. Look out for future webinars, and keep entering the data and looking after our patients. Many thanks.